Talking regarding the distal humerus fracture, regarding the surgical anatomy and the various surgical approaches. The distal humerus fracture, it constitutes nearly 2 to 6% of all adult fractures. 1/3 of all humeral fractures, the incidence is recorded around 5.7 in every 1 lakh in a year. It has a bimodal age distribution. Coming to surgical anatomy, it's basically a triangular piece of bone in the distal part of the humerus. The central area is thinner and comprises of the coronoid fossa and the olecranon fossa. The articular surface is in 4 to 8 degrees of valgus and it's flexed at 40 degrees in relative to the shaft. It's a hinge joint with a single axis of rotation on the trochlea axis. The trochlea is the center point with a lateral and medial column. The distal humerus, as I said, is angled at a degree of 40 degrees with this one, and the lateral positioning during the open reduction, it facilitates the reconstruction of this angle. The trochlear axis compared to the longitudinal axis is at 94 to 98 degrees in valgus. The trochlear axis is 3 to 8 degrees externally rotated. The intramedullary canal, it ends at around 2 to 3 centimeter above the olecranon fossa. The medial and lateral column diverge from the humeral shaft at around 45-degree angle. The columns are important structures for the support of the distal humeral triangle. There are various classification systems, but I'm just going to briefly go through the AO classification as it directs the surgical management and provides information of the outcome of the injury. So, as you all know, this is the AO classification where we have the extra-articular fractures, which is A1, A2, A3, the partial articular, the B1, B2 and B3, and the complete articular surface, C1, C2, C3. Just want to stress that there is a subclassification for the type B3, the coronal shear fractures, by Duberle classification for coronal shear fractures, where it is again classified into type 1, type 2 and type 3. Type 1 being a fracture of the capitulum alone, the capitulum and the trochlea as a single piece in type 2, and the capitulum and the trochlea as a separate piece in type 3. This is associated either, it subclassifies as A and B with a dorsal, presence of a dorsal comminution, absence of dorsal comminution type A and presence of dorsal comminution type B. Operative treatment is the model treatment for any type of distal humerus fractures unless and until the patient is unfit for surgery. To reconstruct the articular surface anatomically must be the mainstay. To achieve a stable reconstruction at an early functional movement should be provided to the patient. The AO principles of an open reduction and internal fixation with a pre-contoured locking plate and a headless compression shoe is the state-of-the-art treatment. Coming to the various surgical approaches, the lateral approach, the Kocher's approach, is through the plane is between the extensor carpi ulnaris and the onconius. An extended Kocher's approach releases the lateral collateral ligament and the common extensor origin, especially when you're dealing with the B3 type of fractures. It is basically, this approach is used for extra-articular fractures of the radial column and the partial articular and the lateral epicondyle fractures, and as well as for addressing the coronal sheath fractures. An incision is made proximal to the epicondyle radial and ends at the radial head. Modification of this, the Kaplan's approach, is when you have to address, when we are planning to visualize the radial head, where you curve this in such a way that it's, the plane is between the extensor digitorum communis and extensor carpi radialis brevis. When we have, similar to that, we have a medial approach. It's an this is again used for addressing extra-articular fractures of the ulnar column and partial articular fractures of the medial epicondyle, as well as type B3 fractures if the lateral approach is insufficient to address the fracture. Here a 10 cm incision is made above the medial epicondyle, and the second step is to view especially the ulnar nerve between the humeral head and the ulnar origin of the flexor carpi ulnaris. So the ulnar nerve needs to be protected. Rest all fractures are mostly done with this posterior approach. Here the patient is positioned semi-prone or lateral with a small radiolucent table at a 90-degree flexed elbow. The incision starts at the distal part of the humerus. It circumferes the olecranon radially and continues the edge of the ulna. So you should not put the incision directly center of the olecranon. The next step is to prepare the ulnar nerve at its axis at the point of triceps. Now there are different variations for this preparation. As we all know, there is through or beside the triceps muscle fibers are possible so as to reach the fracture site. So we have the triceps sparing approach, also called the paratricipital approach. A window is created between the medial and lateral head of triceps and the triceps is mobilized from the humeral shaft. This is while preserving the extensor muscle group. However, the disadvantage is the articular view is pretty limited. Again, when there is a modified triceps sparing posterior medial approach, the Bryan-Murray approach, again in midline incision, the ulnar nerve is identified and mobilized. Then the ulnar fascia, the triceps are shifted en bloc radially to expose the olecranon. At the end, transosseal fixation must be done. We have the lateral para olecranon approach. This is a triceps on approach that is used primarily for elbow arthroplasty. It can be used for extra articular fractures as well. The disadvantage is that to assess access to the ulnar for total elbow replacement is pretty limited. Through the fascial split, it reflects the anconeus superiorly from the lateral aspect of the proximal ulnar. Reflect the anconeus to the posterior elbow capsule from the posterior aspect of the lateral column. You have to elevate the triceps from the posterior humerus as required. Next, when we have to visualize the articular surface properly, we resort to the olecranon osteotomy. There are various ways how you can take an osteotomy. The approach that offers the greater exposure to the distal humeral articular surface. V-shaped chevron osteotomy is created with an oscillating saw and it is completed with a chisel. The inhomogeneous fracture zone facilitates the repositioning at the end of surgery. There are various ways in which you can actually fix the osteotomy. I'm not going into the details regarding that. The articular surface is broadly exposed. However, though the visualization is good, the complication rate is as high as 50% with non-union. There can be implant loosening, implant irritation, and some of the most commonly encountered complications in this. Next, we come into the triceps splitting approach. The triceps tendon is split centrally along the muscle fibers subperiosteally up to the tip of the olecranon. It allows exposure of the shaft to the olecranon fossa. The surgeon should try to preserve the connection between the anconeus and the flexor carpi ulnaris. The Campbell's approach is again a triceps splitting approach which has an extension into the proximal ulna. The triceps is detached at the proximal ulna with the periosteum and radial ulnar flap is flapped to create a wide view of the articular surface. Transosseous refixation is warranted at the end of the surgery. There is also an anterior approach. This is to assess fractures of the capitulum without posterior comminution. The most common way to address the capitulum is obviously the lateral approach. Here, a curved incision proximal to the lateral edge of the biceps, distal to the medial border of the brachioradialis is made. You have to incise the fascia over the biceps and retract it medially. In this step, the lateral cutaneous nerve of the forearm must be identified and protected. The deep interval between the brachioradialis and the brachialis muscle, where the radial nerve and its distal division to the posterior interosseous nerve must be identified. Anterior joint capsule is open and capitulum and lateral trochlear ridge is exposed. So this is a approach where a simple fractures of the capitulum can be addressed, where you can put an anterior posterior screw. Now, just regarding the AO classification and the various approaches that one has to go through while trying to fix the fracture. An epicondyle fracture is an extra-articular avulsion fracture of the ulna or the radial. As a result of the muscle tension, secondary dislocation is inevitable. So, depending upon the particular epicondyle, a medial or lateral approach has to be done, and usually it should be secured with at least 2 screws. But however, it depends entirely on the size of the fragment. So, if the size of the fragment is pretty small, we can get away with a single screw. Metaphyseal fractures are treated with a triceps pairing approach and followed by a 90-degree double blade plate construct can be done, and anatomically pre-shaped locking plates are to be used. To gain sufficient primary stability, at least 2 screws should be placed bicortical and distal to the fracture zone. Coming to the partially articular fractures, that is B1, B2, depending upon the fracture position, a medial or lateral approach is suitable. In the past, surgeons used to only put screws as a fixation, but however, this concept is outdated. A unilateral plating to stabilize lateral and medial column with a pre-contour plate with additional screws is recommended. Coming to the coronal shear fractures, they are highly complex fractures, and owing to the joint alignment, a 3D reconstruction is always warranted. A radial or extended radial approach is used to assess the coronal shear fractures. After visualizing the fracture, one has to distinguish between the coronal shear, multifragmentary coronal shear fractures, and the coronal shear fractures with or without the presence of a posterior combination. Solely coronal shear fracture can be assessed with a headless screw, an anterior posterior direction, as it is shown to have biomechanical stability compared to a posterior to anterior direction screw. AOB3 fractures have either multifragmentary aspect in the posterior combination. The lateral or medial column is primarily stabilized with a plate or a pre-contour locking plate. After the step, temporary fixation of the capitulum trochlear is performed with KYS, and the anatomic reduction is achieved. The osteosynthesis is finally done with headless compression screws. And closure also is depending upon the type of approach and how much you have released. The common extensor origin as well as the common flexor origin are to be transosseously refixed. Anatomical reduction between the articular surface and a stable osteosynthesis should be done, especially with the complete articular fractures. There is a debate whether 90 degree or 180 degree double plate plates can be used. However, biomechanically benefits are 180 degree constructs, but however clinically they are shown to be same. Antiparallel parallel plate positioning was reported to have a superior outcome compared to other ones. Recent studies have shown that proximal fixation is very important. As many screws as possible should be placed in the distal metaphyseal fractures to enhance the stability. Complete articular fractures, dorsal approach or the posterior approach is the thing. One strategy is to reduce the articular block provisionally with KYS, and in a second step, position the block correctly to the humeral shaft following a bicondylar plate osteosynthesis. When the fracture is present only in the radial or ulnar column, it has to be addressed primarily. After repositioning and fixing the first column, a common angular blade plate osteosynthesis, further fragments can be arranged around it. The olecranon groove is serving as a guide for further fragments, so basically to arrange around the jigsaw puzzle. A small note regarding the arthroplasty of the distal elbow. So when you are doing a total elbow replacement or a partial elbow replacement, a dorsal incision slightly radial to the tip of the olecranon. Recommended is again a triceps, preserving triceps on approach. The advantage of this procedure is early function and range of movements and less post-operative triceps weakness. So to conclude, distal humeral fracture is pretty rare and highly complex entity. Multifragmentary uncertain fractures, 3D reconstruction is obligatory. Conservative treatment protocols for only inoperable geriatric patients. There are various approaches, but most important thing is anatomical reduction fixation with conventional screw, headless compression screw, or a pre-contoured or uni or a bicondylar locking plates. Non-reconstructive fractures, total elbow replacement is a viable therapy option. Thank you.